Well, first of all, thank you to the programme committee for the invitation to speak here. Secondly, I'd like to declare that I have no disclosures to make. And thirdly, I'd like to thank all the speakers who've been presenting through the course of the day for doing my job for me. Because I think along the way, we've heard that there may be problems with implantation of devices in HOCM, perhaps in restrictive cardiomyopathies, perhaps in arrhythmogenic right heart problems. Certainly there's a problem with aortic valve disease. Some of these devices cause aortic valve disease, for goodness sake. We're all familiar with mechanical failure, infection, the use of antibiotics, things like that. It's hard to know what an acceptable quality of life is until you don't have it. And we're all very glib about talking about people with devices who have acceptable qualities of life. In the advanced bridge to transplant trial, Hartware had a 7% stroke rate. Is that acceptable? We're familiar with complications related to drivelines, to mechanical failures, and we can't use these devices in small patients. So how can we possibly stand up here, as Stefan is going to do, and say that VAD technology is the gold standard for treatment of advanced heart failure? Whoa, that wasn't it. Okay, I'd like to look at heart transplantation briefly. I'm going to try and flesh out my argument. And many of you will be familiar. The data that I'm going to show you comes from the registries that are held by Ischelt and the Intermax registry. This shows the number of heart transplants by year, of course. And the things that I want to show you are, first of all, the dramatic increase in the rate of transplantation. That was because this was a very successful therapy for patients who had end-stage heart failure. Secondly, we reached a kind of plateau phase when really transplantation was limited by donor availability. And more recently, we've had a phase where there's perhaps been a fall-off of donation rates for cardiac transplantation. And there's some thinking about that. Ischelt have looked at it and blame it all on the Europeans. As you can see from this slide, actually the fall in cardiac transplantation rates is largely due to Europe. And one of the things that may have contributed to that is a tremendous shift towards the use of non-heart-beating donors for other organ transplantation, which means the patients aren't being certified for brainstem death, and so they're not coming through to cardiac transplantation. Up to a third of donations for lung transplantation now come from non-heart-beating donors. So it is a significant change. Now, of course, in the United Kingdom, which is our local patch, there has been a fall in the number of heart transplants being performed annually. And indeed, we even saw it in Papworth, and we're still doing more heart transplants in Papworth than any of the other centres in the UK. I think this year we've probably done around 25 orthotopic hearts. So there is a fall-off in that, and we have a fairly constant number of VAD implants. Now, one of the things about heart transplantation is that it has a fantastic success rate. So the half-life for patients is around 10 years, conditional half-life is 13 years. So that is, if you discount the patients who die within the first year of transplantation, expectation, 50% of them will be alive at 13 years out from the transplant. That's a very, very successful therapy. I'm not aware of that being equalled with VADs at the moment. Perhaps we can consider that later. Within our own programme at Papworth, for orthotopic heart transplantation, 1-year survival is now 89%, our 5-year survival is 75%. And the best numbers for VAD therapy show 2-year survival of around 70%. It's hard to knock someone who looks like this, and shortly after transplantation looks like this, and 20 years after transplantation looks like this, and indeed 25 years after transplantation looks like this. Can you show me those slides from the VAD therapy techniques? Yeah. No. Now, the other thing about heart transplant recipients is that they have fantastic functional life after a transplant. Again, Ischelt registry slides, which show 90% of patients having no activity limitation at 5 years. And as yet, I'm unaware of any VAD patient who can say they have no activity restrictions. Similarly, following transplantation, there is a good number of patients who return to employment. Somewhere around 20% of patients get back to full-time working, and a significant proportion also get back to part-time working. Of course, what happens with devices, which is mechanical failure or some other failure related to infection and so on, can also happen in heart transplantation. And you can see the graft failure line here, but it only ever gets up to around 6%. So even as a leading cause of death, graft failure in heart transplantation is very small in number. Now, what about VADs? Well, look, in the beginning there was all this first generation stuff. They were large, they were complicated, they looked like this. They had this kind of effect on patients. This isn't quality of life, is it? And then, of course, we get on to some other ones, which, second generation, they're smaller, spinning rotors, mechanical bearings, all very nice stuff indeed. They look good. Then we have the new generation, the third generations, continuous flow, hydrodynamically suspended, all sorts of fancy electromagnetic drive systems. They don't wear as much. They're much more reliable in the long term. You don't see the same number of mechanical failures. So all good stuff. But people still have to carry these boxes around their waist or in a pack on their back. And of course there's the drive line. Again, this must place some kind of restriction on patients. So I find it very hard to think that devices such as these can really be being promoted as gold standard for a patient unless there's really no alternative. And of course, I've already told you that heart transplantation is a good alternative. What's next? Well, we've heard about transcutaneous power sources. We've heard that they're going to be made smaller. It's going to be a less invasive implant. Now, why would industry be struggling to put together all those parts of the package if what they had already achieved was the gold standard? Smaller. Okay, you'd like an alternative to this, wouldn't you? So here's the Intermax registry. A significant increase both in implant activity and in the number of hospitals subscribing. It's about 130 units subscribing to Intermax registry now. It shows again a tremendous growth in implantation rates. But here's the survival. And I do believe that shows 50% survival at 4 years. Did I just remind me what I said for heart transplantation? Yeah, okay. Much better than that. Here it is by era, because of course the VADs are getting better, aren't they? The red line is the new era, but still the survival does not approach that for heart transplantation. Here it is for pulsatile devices, okay, and here it is with continuous flow devices. So the continuous flow devices have improved survival, but still, you see that 4-year survival is only around 60%. This is not gold standard stuff when you compare it to cardiac transplantation survival and quality of life. We haven't talked much about the problems yet, but there are big problems. Hemorrhage, thrombosis, hemolysis, infection, neurological events, system failure, those are all problems of the mechanical devices. Would you want to walk around with this on you? Here's a driveline failure. That's the most terrifying thing for most of these patients, because if they're completely dependent on a device and their driveline fails acutely, then they could be in severe trouble. Here's another driveline failure. So the driveline remains a weakness. It cannot be regarded as gold standard. With infections like this, infections that require further interventions, and of course infections that ultimately can ascend to the drive, to the machine itself, so within the pocket or within the pericardium. And I'm grateful to a colleague who gave me this slide, which showed the timeline for one particular patient who'd had a very severe problem with a VAD infection. You can see, if you look at it, that there was input from plastic surgeons, deep pockets, erectus abdominis, myocutaneous flap, debridements, all sorts of problems like that. Again, this cannot be seen as gold standard. When following heart transplantation, this kind of infective sequel is not a big problem. Now, the reason that infection in VADs is a problem is that it makes a significant outcome on, a significant impact on survival and outcome. You can see that most of the infections are early on, but you can also see what happens to patients who have an infection. So very quickly survival is adversely affected. Of course, quality of life also bears some consideration. And one of the issues is that patients who have VADs in are disqualified from driving. And most patients, I accept that CCS has now redrawn that. Commercial driving is still a ban, And as of 18 months ago, private driving is now possible with continuous flow devices. There are other problems with gastrointestinal bleeding for both pulsatile and non-pulsatile devices. Interestingly, there is a lower rate with the non-pulsatile devices, but it's still there. Non-pulsatile wearers acquire von Willebrand syndrome after implantation, so there are coagulation products which come to life after implantation. So, in conclusion, I would say that there is a survival advantage which remains for cardiac transplantation over the use of VADs. The limitation to heart transplantation still remains the donor availability, and we should be working very hard to improve our ability to take hearts from non-heart beating donors, to improve the donor pool. Quality of life is certainly better following transplantation. And of course it's right that VAD therapy will continue to develop. Absolutely right. It needs to happen in parallel. And I would suggest that promoting VAD therapy as the current gold standard for treatment for advanced heart failure, when there are so many issues remaining, casts doubt on our credibility as surgeons. Thanks very much.